Good morning, everyone. My name is Maya Luria with TMC for Seniors, and we are wrapping up our Brain Health Month with a really important topic. We're going to be talking about the role of physical therapy after stroke. I have Geneva Kaplan Smith with me here. She specializes in stroke. She's a physical therapist over at our TMC outpatient therapy. How are you today, Geneva?
I'm great. How are you?
Good. I'm so glad that you're here. I know you work with so many of our stroke patients over here, and you really have a passion, and I'm excited to hear what you have to share with us today. So I'm going to go ahead and put your PowerPoint up. We do have an online audience along with your in-person audience. So if you're watching from home, please feel free to leave any questions for Geneva in the chat, and I will ask her afterwards. I'll let you go ahead and get started.
Okay, so as Maya said, I'm Geneva Kaplan Smith. I'm a physical therapist, doctor of physical therapy. I'm also a certified athletic trainer, a board certified specialist of geriatric physical therapy, and a nationally certified Pilates teacher. That's where all those alphabet soup is, in case anybody was wondering. So. And stroke is a near and dear topic to my heart. I actually had a grandparent who had a stroke right as I was going to physical therapy school. And she unfortunately was stuck in a skilled nursing facility. To my knowledge, did not get great care, was just kind of either in bed or in the chair, didn't really have a lot of opportunities to move. And so that's why I'm really passionate about, trying to make that not the norm for all of my patients. And yeah, definitely hits home. So just really briefly, what is a stroke? According to, I believe it's the American Stroke Association, stroke is the number 5 leading cause of death and the number 1 leading cause of disability in the US. And 90% of strokes are ischemic, meaning there's a blockage of blood flow to the brain, and that's what causes all the infarcts and things we see. 10% of strokes are hemorrhagic, meaning a blood vessel has burst, and that's what causes the tissue damage then. And there's quite a variety of how this can affect people. I've seen patients that their only deficit is their vision. They have like a field cut of their vision, or some patients that are just quadriplegic and they just can't move nearly any limb and everything in between. So it really depends on what part of the brain is affected. So in terms of specific to PT, this is kind of our scope of practice. The American Physical Therapy Association defines it as trying to optimize physical function, help in movement, performance, overall health, quality of life, and well-being across the lifespan. And again, that's also looking at public health, so just prevention of everything, trying to improve our human experience overall. So another piece of my role as a PT in the realm of stroke is always screening for referral. So determining, what is in my scope to see a patient and what other services do they need? Because a lot of times there are gaps in that, especially when they come to me an outpatient. And so what does that team look like? It's their care partners, people caring for the person who's had a stroke. It's physical therapy, occupational therapy, speech therapy, mental health providers, the primary care physician, the neurologist. There's more than that list, but those are the big ones that come to mind for me off the top of my head. And I think just a really important piece in terms of the overall picture of what are we doing for people post-stroke is where's their attention? I love Eric Franklin. He's a wonderful educator of movement, universal movement. And he talks about how attention is the beginning of change. And this is a really important piece because a lot of times people will stop using their affected side. They don't pay attention to it. And as a provider, my job is to shift their attention to what will make them move better and pay attention to that limb again. And Ellen Langer, who's a wonderful Harvard psychologist professor, she talks about this idea of mindfulness. And everybody thinks mindfulness is meditation. Not necessarily, But her definition of mindfulness is this idea of I'm paying attention to all the details in my environment. Instead of just mindlessly going through your day, it's like, okay, what can I notice in my environment? Is the sun shining differently? Are the plants in my yard looking differently? Like, what other details in my environment show up? And especially when it comes to recovering from a stroke, how does that manifest in your body? How am I feeling in different parts of my body today? How does that affect a certain task I want to do? Can I get to the bathroom? Like, all those little details matter. And it's easy to go through life and not pay attention to those details. So I think that's a really interesting definition of, well, what is it to be mindful? And how does that affect our rehab, our recovery, and also just wellness? My other favorite example, again, with Ellen Langer, she talks about, if everyone's familiar with the Snellen chart, when you have your vision tested, it goes from big to small print. She did this great study where she flipped it and made it go from small to larger print, and everybody's vision tested better. And it's like, what is that about? So anyway, perception and attention are a big piece. It's like, how do I perceive my environment? What am I paying attention to? What do I expect is going to happen? So I'm going to go into more detail, but in terms of physical therapy, these are some big things that I'm screening in a patient. It's, what is going on with their vision? What's going on with their inner ear, that vestibular system? Can they tell if they turn their head? Does that information go up and say, okay, I felt that my head turned? And then do they have intact proprioception or kinesthesia? And those are fancy words for saying my joint position sense is proprioception. So did I move my hand forward? And then kinesthesia is I'm moving my hand forward. So this act of I'm moving and I'm sensing movement versus is my joint in a different position. So a static sense versus a moving sense. All of those systems kind of work together to tell me, okay, I'm upright. Like, how do I interact with the environment? So in terms of balance, this is the three pieces we're looking at. So just a kind of an overview, and I'm going to go into more detail on these three things. But what are PTs doing for someone after a stroke? The big thing everybody thinks about is walking, right? Gait training, working on balance, as I mentioned. And then task-specific training is a really awesome topic. One of my professors wrote a whole book on this topic. And I haven't read the book, I'll be honest, but I did attend a talk that 2 OTs did actually this fall. So we'll go into more detail on that about her topics. So the big thing that people want to know after a stroke, when they come to me usually, is when can I return to walking and driving? And also, I'm sure their dog wants to know if they have a dog, can you get back to walking me? All the things that we did before a stroke, can we get back to those things? But those are the two things I hear the most. We know that 54 to 80% of people who've had a stroke have trouble walking. That's big. I have seen many patients where the only deficit they have, again, is visual, or maybe it's just that they can't speak or they can't move their arm. It really varies based on what part of the brain was affected. In terms of the energy required, it takes more energy to walk, more attention, like I mentioned. It's more difficult to balance. And that's huge because just having to pay attention to that, it's like, well, then I can't do other things I want to do, Something very interesting I found too, and this is something I've seen clinically as well, somebody walking forward versus walking backwards. We have data that we can predict that someone has a cognitive impairment if it's harder for them to walk backwards. And it's just fascinating because, again, I will measure this in the clinic all the time, and I can say, even without measuring anything, okay, they probably have trouble thinking if it's hard to walk backwards. It's just a different program. The other thing that's fascinating is this idea of walking while talking. So we know that if somebody is walking along and they have to stop in order to converse with somebody else, then they're more likely to be a faller, actually. It predicts that they're going to fall. So it's something that we're looking at in terms of PT, like, can I dual task? Can I do two things at the same time? And how do we add that in safely? Because maybe while they're in rehab, it's not smart to try to do two things at once because that could make you fall. So interesting stuff. If you look at the clinical practice guidelines in terms of the American Academy of Neurologic Physical Therapy, they got a bunch of clinicians together and looked at all the evidence for retraining walking after a stroke. This applies to chronic stroke, so after 6 months after a stroke. and also spinal cord injury. We have guidelines that say that if we force someone to try and walk faster, like intense repetitions of stepping, that will drive neuroplasticity or good changes in the brain, and that will improve their aerobic capacity. Just all kinds of good things happen. We know if we do aerobic exercise, it increases blood flow to the brain, and basically everything after a stroke improves with that, including memory, cognition, all the things. How do we do that? It's using, walking over ground. I love using a treadmill when that's safe to do. Not everybody's safe to get on a treadmill. And then stairs are huge. And we really value safety. It's like, I'm not going to just take every patient and throw them on a treadmill and say, go as fast as you can. Like, that's not what this looks like, in case you're wondering. We have some really specific guidelines for saying, okay, first of all, like, are they hemodynamically stable? Meaning, is their blood pressure stable? What's happening with their blood pressure when they're resting versus when they're active? And then we have some really, really pretty specific guidelines about how intense are we going to make this person work. Usually we want to keep them in the range of their heart rate max being 70 to 85% of their maximum heart rate. And so that will also depend on if they're taking like a beta blocker or something that will blunt their heart rate response to exercise. So we can't always start with high intensity walking for many obvious reasons. Sometimes my clients just can't stand up long enough in order to get them on a treadmill safely to force that. And so we have to respect that and kind of see where they're at. But yeah, there's a lot of things we can do in this realm. So, and then in terms of what specifically are we doing? We want them to work at a moderate to high aerobic intensity. And also the clinical practice guidelines recommend that we train walking with virtual reality if we have it, which I wish I did. But this idea of giving some different visual input can really help people to then, move their body differently. So just the power of our visual system. It's fascinating. The other thing that we can consider doing in terms of improving walking after a stroke, according again to those guidelines, doing strength training, where we're working at 70% of someone's one repetition maximum. So let's say they were lifting 100 pounds, and they can only do that once. We're going to say, okay, can you lift 70 pounds and train that a bunch? Because strength training is so important too. It's like if I don't have the strength to stand up and push against gravity and climb the stairs, it's really hard to walk. They also recommend circuit training, so doing different intervals of exercises to build strength and aerobic capacity. Cycling on a bicycle or like a recumbent stepper. And then we also recommend balance training with that virtual reality is another useful piece that, again, there's evidence to support. So just as an example, in the clinic, a lot of times I'll have people, if they are safe to get on the treadmill, like just start walking at their comfortable speed and see where we're at. It's like, I like to say, okay, if you can stand up for 10 minutes and go, then I can really start to push you in intervals of like, okay, 30 seconds, as fast as you can go. And then we're going to monitor vitals and see what happens with you. And doing that on and off of I'm working and then I'm resting. And then I like to have them try to find their top speed again and see, okay, can you work at that top speed? And the treadmill really forces that. So just a nice tool. So just in terms of walking speed, a lot of people will say this is like our 10th vital sign, how fast we can walk. I came across one article that said that in terms of efficiency after a stroke, so it's like energy-wise, the goal is to get someone to 0.8 meters per second, or 0.8 to 1 meter per second. And just for reference, 1 meter per second is about 2.2 miles an hour on the treadmill. If you're like, how fast is that? All the literature is in meters per second. So your phone will also say that too. So if you're like, how do I know what this means? We know that if someone can walk at least 1 meter per second, they're going to need less assistance with their activities of daily living. And in terms of crossing the street, we actually have some really good data about like how fast is the street timed, right? This is a huge deal. According to what I've read anyway, they're saying that 1.6 meters per second is like the speed that those timed lights are set at. I don't know if that's true everywhere. I actually came across a very large road in Tucson. I was going to walk across, and this is a 4-lane street with turn lanes. It's huge, right? We're talking about 6 lanes I'm walking across, and there is a median in the center. So if I needed to walk across and rest, I could, right? It gave me 40 seconds to cross the street. I was like, this can't be right. I'm going to actually go out there and time this sometime to see if this is right, because that seems like a long time. Anyway, just some very interesting, like, functional data to consider, because, hopefully crossing the street, you take it for granted. Let's see. So again, yeah, if there's a median, that changes everything, right? It's like, how are we designing our cities for this? Like, not every street has a place to stop and rest. So can I speed up and get across the street safely, And then in terms of, like, I just love this picture of this idea of, okay, we need to work on climbing stairs. Like, Tucson is not flat. Patients tell me all the time, oh, I don't have any stairs at home, so I don't care about that. It's like, no, like, you need the ability to climb up and down a curb. It's like, there isn't always going to be a cutout, hopefully, but it's like all these things of, how do we train walking? And we know that if we work on climbing stairs, that will help walking on a level surface too. So we need all of those things. And then I love this picture, just the idea of, like, we need to get out, we need to get sunlight. I really make it a point to get my patients outside when we're doing all these tasks, because we know that getting that natural light is huge. A lot of patients after a stroke are depressed. So it's like getting that sunlight, getting the wonderful things that come off of our trees that make us feel good and help our immune system. So, I couldn't do a talk without this slide. I know it's terrible. I just love this. This is like a ton of data on, okay, if I walk a certain speed, this is predictive of XYZ. Now, especially considering just how much uncertainty there is with everything after a stroke, I think we have to take all of this with a grain of salt. There was a study, I believe it's 2002, that said, oh, okay, whatever you get after 3 months after a stroke, that's what you get in terms of recovery. And that was 2002. And I still hear doctors say this all the time, like, okay, yeah, that's all you're going to get. And it drives me nuts, because, I mean, yeah, maybe there is data to support that. That's not every patient. It's certainly, it's not black and white. And so anyway, it's really frustrating to me, because I hear that all the time. And I think it really depends on what the patient puts into things, what work they put in. And also, we know it's like, if you aren't, like, they used to say, okay, when you have a stroke, the deficits you have, like, initially, that predicts everything. And it's like, no, like, well, what rehab did you get? What was your environment? What was your nutrition? Just so many factors. So anyway, we know in terms of data, if we can walk at 1 meter per second in that green zone, or the 2.2 meters per second, or miles per hour, excuse me, you're less likely to be hospitalized. You're more likely to be able to do your activities, like I said, grooming yourself, bathing yourself, dressing, cooking, all the things we think of. And then at the very far right bottom, you'll see it says cross the street safely. That's like 3.1 miles an hour. So that's what they say in the data. Again, it depends on what street we're crossing. There's so many interesting factors. So let's see. Okay. In one study I looked at, we know that after a stroke, 70% of people will have a fall. This is a really frustrating thing as a therapist, because I know that I can't prevent every single fall, but it's like, knowing that, well, what can we do to reduce the risk? There's like 400 different factors of why we have falls. So it's a lot. We have whole talks about this, but I think an interesting factor when it comes to stroke is this idea of what happens when I try to turn when I'm walking. Clinically, I hear it all the time. Oh, I turned too quick and then I fell. And so clearly that's a problem. And I love the statistic. I don't know where I heard this. This was years ago. The average person actually makes about 1,000 turns a day. This is walking around an average home. This is not a mansion, but just to walk around your home, like a normal home. So can you imagine, if every time I turn, I fall, that's huge. And I love this other, this is coming from a study I was looking at, actually it's on the next slide. As far as how much of our walking is turning, someone tried to quantify this and say it's 20 to 50%. So we're never walking in a straight line, really. Is anybody? We're just zigging and zagging everywhere. But yeah, can you imagine, I'm walking around the house and I'm doing this in the kitchen and I'm going to the bathroom and everything is a turn. Like, we don't walk in a straight line. So Anyway, this is something that I think we need to do more with patients with stroke. Another study I was looking at was talking about this idea of just using vestibular rehab for people after a stroke, and meaning that we're training them to move their eyes, to move their head, to work on stabilizing their gaze. So I'm staring at an object and keeping my eyes on that object and moving my head in space. And that those three things alone are something we should be working on with people post-stroke, assuming that applies to them. Again, it depends on the stroke. But if that's why they're falling over, it's like, why is that happening? Why is turning such a trigger? A lot of interesting thoughts I have for you on that. But yeah, a lot of times people will not turn their head after a stroke. They'll just be attending to the unaffected side, or maybe they have a visual problem where they just don't pay attention. They have a visual inattention to one side. So this is huge. It's like, can we just get people to move their head more? Lots of considerations here. And let's see. So this is, again, that study I was going to reference. So if somebody is afraid of falling, they were more likely to turn slower, even if they weren't a faller. It's like, what? Like, this predicted that they were going to fall more if they were afraid of falling. And we know turning to someone's unaffected side, they would do it faster than going to their affected side, which makes sense. It's like, what's going on that side? Can they even feel that side? But this is fascinating because that whole idea of like, how does fear of falling affect just, everything we do? And where is our attention when we're walking if we're just afraid of that? So, we know that more than 50% of people who've had a stroke often have problems with their cognition, that higher level thinking, working on things like finances, stuff like that. And especially when it comes to falling, this is huge. This is something that, again, it's frustrating to me as a PT because I can only do so much with someone and their physical pieces. But if it's hard for them to think and plan ahead, and maybe they make a choice because of this that's not their best choice. I was talking to a client recently, and it's like, they had a fall that wasn't witnessed, and the caregiver is just like, I don't know what caused it. And it's like, well, maybe that person just made a choice to like reach outside their base of support. And if they had had an intact ability to think about it, that wouldn't have happened, So there's only so much that we can control there. And a big reason for people to see speech therapy too, and occupational therapy, both of those disciplines really talk about the cognitive side of things and the safety awareness piece and thinking about how do I rehearse things. There is some overlap in PT, but a lot of times I'm looking more at like, okay, can you dual task? Can you think and walk at the same time? I don't recommend that people text and walk at the same time if that's going to make them fall over. If I know that they have to stop walking just to talk to me, probably they shouldn't be texting and walking. So in terms of balance tasks, I love this picture. So this is such an interesting area. There's so much that we could look at here. I had another client that had a stroke earlier this fall, and they mentioned to me that they sat down on a curb and they couldn't get back up from the curb. And I'm just like, oh, okay. Like all the flavors of getting up and down, like what is functional, and again, like maybe it was hard for them to think about that. And so they couldn't think, oh, maybe that would be hard for me to get up and down from this curb. And then they're just stuck down there and they need help to get back up. And so lots of things we need to work on here. Again, like one of the things I've really been trying to focus on with clients is this idea of, just moving their eyes. Anything to get them to turn their head and move their eyes is huge. We know that if we can move our eyes quickly, we call it like a saccade. So can I jump my eyes from one thing to the other? That alone will make me more stable. But also there's a reflex at the bottom of the slide here, the vestibulospinal reflex. And this is just one reflex. There's so many reflexes that are constantly keeping me upright. But I love this reflex because basically this is when I turn my head, it fires all the muscles on my spine to say I'm upright. So it's like this idea of if I turn my head, what keeps me upright? But it needs to be all directions. It's like, is there a directionality of if they look up or they look to the side, like what throws that person off balance? I didn't mention this earlier, but one of the things we see a lot with patients, especially if they've had a fall, is they might have some vertigo going on. And is that even being treated? Because it gets missed so often. If someone has a fall, those crystals in the inner ear can get knocked out of place, and then I'm not getting good information about where my head is in space. And then it's like, okay, that's a problem. So 1 in 10 older adults is walking around with vertigo and has no idea this is happening. And we all should be screening for that more. So, because dizziness is such a black box, it's like we need to be more specific. And if someone you know is dizzy, like tell them to go see a PT, or at least screen out why are they dizzy. Especially if it's like, oh, I changed positions, my head moved, and then for a few seconds, I'm feeling the room spinning. Sometimes we can treat that dizziness, but there's so many reasons to be dizzy. So that's a big one. So I love this picture, just kind of an idea of like, oh, what does balance look like? And also in the far left picture, this idea of, okay, after a stroke, we have data on where do people put their weight. And typically, I'm constantly talking about this with people. It's like, well, we're going to the side that we actually know exists. They're usually putting more pressure on their unaffected side. And I'm constantly trying to get them, can you come back to the middle or load your affected side? And so it's really interesting, like, well, maybe that's why they can't turn or why it's hard to turn, because if I'm constantly on my unaffected side, then of course I'm not going to be able to shift my weight and take a step and not fall over. So really important stuff. So this is a really cool study looking at some of the biomechanics of stepping, because we know we have 3 major balance reactions, right? We have our ankle strategy, where I sway from my ankle and everything else stays pretty still. We have a hip strategy where my hips are the place that I'm moving from. We have a suspensory strategy where I just lower my center of gravity, and that's how I keep my balance. And then if the wind blows me, I might have to take a step to not fall over. And so we know with people who've had a stroke, they're really reluctant to step with their paretic leg or their involved leg. And this is a big deal. This is probably why they're falling, But anyway, Pollock looked at, she had people hooked up to a harness system, so they're safe, obviously, we need to be safe. And she had them lean forward and then they just said, like, fall like a tree and allow them to just like try to have to take a step and catch themselves. And she asked them to either step with their involved leg or their uninvolved leg and just look at what happens and how long does it take them to do that, and what does that look like in terms of all their joints, like what's happening there. And the big thing that was interesting that she found was basically people who, their control group, they were able to bring their center of mass, so like their belly button area, they were able to take a really big step and catch themselves, like a large drift of like, I'm leaning and then I'm catching myself. Versus people who had the stroke, they really couldn't generate that larger step, and they couldn't control or absorb what was happening. So they couldn't get their leg out in time, and then they couldn't bring their knee and hip up enough to get their foot out there in time. And so we know this is because a lot of times after stroke, we'll see too much of the extensors kick in, meaning the front of the thigh muscles, the quads, the things that straighten your knee, and the things that lift your heel, those 2 muscles, the calf and then the quads, sometimes they're too active. And so we get this like tone, or this, this abnormal muscle tone happening, where it's hard to create that bending of the knee, bending of the hip, and to pick up my leg to step. And so that's the big thing that they were looking at. And so anyway, just this idea of, can I absorb shock on that side, or can I move my leg and get it under me in time? The speed and the distance that they needed was not sufficient. So this is something that we're always trying to train in the clinic. It's like we have the ability to hook people up to our nice solo step system. And And so I can actually do some slip training with people where I will pull a leg out from under them and have them try to step. Now that sounds evil, but it's like, I want to test that. It's like, it's something that is part of my balance testing. It's like, I'm going to ask them to go in all directions and lean, and then I will take away my hand and ask them to step. And if that's hard for them to do, like, we need to work on that. So in terms of just the results of that study, like I said, the control group, they had a bigger displacement, so they could move their whole body in a bigger way and move that center of gravity forward more. And their steps were faster and longer than the people who had a stroke. And then really interesting, this idea of, okay, how many steps does it take for me to catch myself? Ideally, it's like if the wind blows me, I can just take it in one step. That's like normal. I hate to say what normal is, but according to one balance measure that we use, that's considered like acceptable, is I can take a single step and I'm not on the floor. So this idea of if I took multiple steps, that's considered impaired. So again, if the person who had a stroke, if they took their first step with their paretic leg or their impaired leg, they actually had more trouble because then they had to stand on that leg. So they had to take multiple steps to catch themselves, versus if they took the first step that they did was with their non-involved leg. So another piece I think that really becomes important, especially with all of our data on falls, is just this ability to get up and down from the floor. And if you look at some literature, like I said, Tonetti would say that it's actually considered a sign of frailty if someone has trouble getting up from the floor. Now, obviously, if they had a stroke, that's a different story, but just in a normal population, if it's hard to get up and down, that's a sign of some weakness. And so this is something that we always try to work on with patients, assuming it's safe to do so. Again, a lot of times it looks like, okay, I'll put somebody on a mat that's lifted, I'll bring the floor to them and have them work in hands and knees and say, okay, like what are the pieces of that we can work on? You know, what's the next step that you would do going from hands and knees to get yourself up? There's hundreds of ways to do it. But just this ability to get up from a fall too, it's a huge deal. It's like, we know all of us are going to lose our balance. It's a matter of, do we catch ourselves? And then can we get up from that? You know, I had a gentleman the other day that was so excited. It's like somebody in their 80s and it's just like, you know, oh, like the wind blew me, but I spun around, I caught myself, and they're so excited. I'm like, good. I'm like, that's normal. Like we all lose our balance, like, you know, as long as we can catch it. So yeah, this is something that definitely, I think it's definitely a fear for a lot of patients too. It's like, okay, you know, I want everyone to have the ability and the opportunity and the option, if they would like, to get up and down from the floor. There's lots of cool stuff to do there and lots of reasons to have that ability. So in terms of the task-specific training, you can see in the picture, this could be almost anything in terms of what patients are needing to practice. We used to think, oh, like we'll do all these general things with patients and hope that helps with what they need. And it's like, no. Again, my professor, Catherine Lang, actually wrote a whole textbook on this. And just this idea of, okay, if we want to learn how to do whatever task, we need to practice that task specifically. And how we do it is important. It's like, well, how can we grade the task so that it's easier to do it so the patient has some success? It's like, you know, do we do things that kind of make their limbs lighter so that they can move them through space? Do we change the environment so it's like, okay, gravity is assisting me to reach for something instead of having to go against gravity? And then how do we make that salient to the patient? Like, it's like, if it's not important to them, it doesn't matter. So this is one of my favorite examples. I think I was trying to go back and think of how many people have done this, but I had at least 3 people that I can think of off the top of my head that are equestrians. They're like, I want to get back on a horse and I've had a stroke. And so how do we do that, right? It's like, obviously don't have a horse in the clinic, but my favorite example, I'll go get a chair and say, okay, I'm going to have you like step over the chair because that's high enough to like kind of simulate this. And so how do we break down this task of getting on the horse? Well, you have to stand on one leg and swing your other leg over. So it's like, I'm breaking that down and giving them the static horse, you know, to do that. And then like different ways of, okay, maybe we up the ante and they do that and swing their leg over like the rail of the stair. Like what else is actually the task without having a horse in the clinic? Yeah, this is really fun. So, and I was going to say, I had a gentleman that like literally went back to, okay, like I'm gonna actually like be fully controlling these horses after a stroke. I'm like, that's wonderful. Like, it's like, okay, it's possible, you know? So I'm sure you've probably seen some of these principles before. There's so many versions of this list. But again, going back to the idea of attention, like what am I paying attention to? We know if we don't use it, we lose it. And this is why after stroke, it's like the affected side often just is learned. We learn not to use it. And that's why it's like our job as a PT, as an OT, as speech, whatever we are, is to bring attention to that so that we can integrate that limb back into function. And then the specific adaptations with imposed demand, that third one is, again, that specificity. So it's like,
what did you say? What is number 3?
The SAID principle is an abbreviation for specific adaptations with imposed demand. So this idea of specificity, again, if I want to teach somebody how to swim, I'm not going to put them on a bike. Like that's not going to transfer. So it's like, how do I make the task specific to what they want to do? We know repetition is huge. When I was looking at Catherine Lang's book, she talks about this idea of, okay, how do we make a task easier or harder? How do we decide how to modify the task? Is the patient, are they having success 90% of the time with doing the task or not? And can they do 100 reps in a certain period of time? And that's 100 reps, right, within the session. And I tell patients all the time, and they're like, 100 reps. And I'm like, how many thousands of movements do we do with our limbs? And we don't even think about it, like in a normal state, right? We have data on this actually from Catherine Lang too, about what is the normal use of our limbs. We know that we will use our dominant hand about 8.5 hours a day and our non-dominant hand about 8 hours a day, but we use them together the most. It's not just like one limb is doing everything, right? There's a lot of issues of people overusing their unaffected side after the stroke because that's doing everything now. So just getting those repetitions of I'm using that limb and changing it and doing it in a way that's going to stick. Intensity we talked about, it's like if it's not intense, it's not going to drive that change. Novelty is my favorite thing. It's like, okay, how do we make the task somewhat new or fun or different so that the patient's like, oh, I'm going to use a different pathway and think about this in a different way. And then again, salience matters. I love this idea, again, back to Ellen Langer. She talks about this idea of, oh, are people with dementia not dementia, but if they have a memory problem, do they really have a memory problem or they just don't care about remembering whatever it was? And I'm like, that's an interesting way of framing it. Like, if we don't care about what we're practicing, then of course it's not going to get better. It's like, this is a waste of everyone's time. So anyway, I love that. And then is it generalizable? So again, the idea of the horse, right? Can they take this movement of standing on one leg and swinging their leg over the horse, over the chair, right? And apply that to what they're trying to do. And then I'll talk about contextual interference. We got the slide on this. Mike will just go to that first. This one, I'll go back. So contextual interference is this idea of when I ask somebody to do a task, and the example here is standing up from a chair, right? What are the demands of that chair? Is the chair going to swivel like the bar stool here when I sit down? Is there a back on the chair? How high is it? And then am I going onto a low couch? Like what is going on with that movement? How can I change the environment? So the person's practicing a lot of variety of movement so that way they drive that learning of the task. So instead of just saying, okay, can I sit to stand from an 18-inch chair, which is a standard chair, over and over and over again, which is a wonderful thing to do if you just want to get stronger. But if I want to change how that person can then, go out and do different things in the environment or get into a booth or, sit on a moving bus or train or something, that's not going to cut it. It's like we need to have this change in the context so that the person can, sit on a very low toilet. We need to practice a variety of movements. It's not just, okay, I got up from the standard chair over and over again. So I'll go back. Okay, I think we're there. So we know that 50% of people who've had a stroke have impaired proprioception and kinesthesia. And in case you forgot, again, proprioception is the sense of that static limb position. So it's like, oh, my arm is over here. And then kinesthesia is I'm moving my arm away from my body. So just the idea of I'm moving or I'm not moving. And really important because if we don't know where our limb is in space, how can we use it? So a big deal in terms of just general things we'll do in neuro rehab is, this is why we work on weight bearing. And so like, how can I give myself this feedback from the environment so that I have more sense of where I am in space? And I get really excited in the clinic when someone finally stands on their affected side long enough to say, oh, I can feel my affected side. I'm just like, oh, ding, 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 like we have a winner. And so traditionally people think of this picture as weight bearing, right? Weight bearing is just in this direction, it's down, that's all it is. That is not weight bearing. Weight bearing is in three dimensions. My favorite picture here, it's like, okay, this person's weight bearing, right? They just happen to be upside down, but like there's weight bearing happening in their feet and their knees, you know? This person is also weight bearing. It's like, okay, a lot of times I'll ask the person to use their affected side to stabilize and then use their unaffected side to move. Also, just because there's some fun connections. If I let's say my right hip or my right side is my affected side, and I want to work on getting that hip going, I will lift my left arm because they're connected. They're slings of muscles. When I lift my left arm, it makes me straighten that right hip. So again, it's like, you know, where is the weight bearing happening? Is the person loading their affected side? And again, it's in all directions. It's like we have some fun tools in the clinic, some PVC and different things we'll use to alter gravity, to play around with, okay, can I go in all directions? I want to move that arm in all directions. We talked about that. Okay, there's a bunch of cool things I want to tell you about. You might have heard of like Vivistin. That's just one example of something for ischemic stroke. People are doing vagus nerve stimulation, where they will stimulate the vagus nerve, which is one of your cranial nerves, and that will change the neurotransmitters in the brain and can drive neuroplasticity. And for those patients this is appropriate for, I mean, it's an extensive surgery where they're putting in a stimulator and doing all kinds of cool things. And then we're using that in therapy to try to wake up things. So they will like click or use a magnet to turn on the stimulator while they're doing therapy. And that will drive changes in the brain. And I've actually had a couple clients who've gone through this. And it's so exciting because one in particular, I think, is like 5 or 6 years out from their stroke. And it's like, it's a whole different ball game. It's like, again, that whole idea of, oh, after 3 months, this is all you're going to get. Well, not necessarily, but it's like, if you're going to put in the work, like this only, you know, this is not a great option if people don't want to put in the work, because then you've gone through all the surgery for no reason. But for those clients, they're like, I want to do the work and they're appropriate for this. This is awesome because it's like, it's going to drive those changes in neuroplasticity. Obviously, not everybody's a candidate for Vivistin. So what can you do if you aren't? I mean, just doing intense aerobic exercise, we're going to get more of this brain-derived neurotropic factor, which BDNF is just a long word for basically brain glue. It's the stuff that helps make new connections in the brain and change the brain, keeping everything, you know, connecting. So something else that I came across in terms of just some other cool things. I was at a conference in October, and they're working on a device where we use the auditory system to help patients to walk faster after chronic stroke. And the device is called an Intune. And what they do, they have sensors in their shoe, and then they have these earbuds. And you're walking to music, and there's an algorithm that helps the person walk to the beat of the music. And the coolest part is the patient gets to choose the music, which is so important because, you know, who wants to walk to music you don't like? Anyway, just some other examples of using like a rhythmic auditory stimulation, which is a fancy word of saying I'm walking to a beat, right? Walking to a metronome. There's some cool data on that too about just like, okay, if I'm trying to match a beat, that can change the brain in terms of the timing in the brain, that, you know, timing and working on those kinds of things is distributed throughout the whole brain. So again, how can we change attention? How can we change what people are focusing on? And does that get them to do, you know, to walk faster is the idea with that Intune device. And I mentioned earlier just really briefly about the issue of depression. It's like we know 11 to 41% of stroke survivors have, within 2 years, will have some depression. Understandably, it sucks. And I have to say there is some hope in terms of movement. It's like we know that depression symptoms, they decrease right after someone exercises. So it's really interesting if you look at outside of the world of stroke, what are people doing for depression? Aerobic exercise. They're actually prescribing this now. Instead of saying, go take antidepressants, they're like, go exercise, which is so interesting. It's like, okay, it's free. There's no side effects typically. Anyway, we also know that both exercise and mindfulness can regulate inflammatory factors. And they can increase that BDNF, that brain glue. So just moving can really help with depression. Oh, and then so again, looking back at the clinical practice guidelines, people are always asking, should I be bracing my affected side? Should I use some e-stim? We know there's evidence for using both of those devices if somebody has trouble moving their limb after a stroke. And anyway, just something that can be useful in the clinic. Sometimes we'll throw e-stim on people. And let's see. Overall, our big goal is just, can we change the movement opportunities that exist for that person? It's like, what do they want to do? What are they currently doing? How do we use gravity and all of our tools and supports in the clinic to make that happen? And then I always like to say PT should be like the dentist. It's like, you should do a checkup. Like in general, in terms of outside the world of stroke, we talk about like come in for a musculoskeletal checkup once a year. But especially if you had a stroke, it's like maybe it's every 6 months you check in and say, okay, where am I at? Is my balance any better, worse, the same? Can I update what I'm doing at home? Maybe I need to do a tune-up and do, a month or something of therapy to try and get up and stay up at the highest level possible. And again, if you're somebody who is like, oh, I haven't ever stopped working on this, it's like, there's some patients that just put in the work and it's like, yeah, like we can keep upgrading things because they're continuing to show this, like, yes, like we're making changes that you need our support doing that. And it's really, I know that can be really frustrating because it's like, okay, all these things with insurance and like, how do we justify the medical necessity of what we're doing? And it's like, of course, like if you're my family member, like I want you just to keep doing PT, but it's like at the end of the day, like, what's going to give you the best long-term option? It's like, well, maybe it is coming in every 6 months and let's update things, but it's like, it all depends on what the patient's willing to put in. And can we make those changes that are meaningful and useful? It's like, so, that was a lot of info. What questions do you guys have?
So thank you. So thank you, Geneva. So I do have some questions that came in, and I have to tell you, I'm totally fascinated about the 1,000 turns a day that we are making. And I was like, wow, that's a lot that we don't think about. So can medications impact your physical therapy and your recovery as well?
Yeah, I mean, just we know if you're taking more than like 4 medications, that is a risk factor for falls. There's so many issues with medications. It's such a frustrating thing. I mean, I'm constantly trying to, I'm not a pharmacist, but I'm constantly trying and like reviewing meds and say, okay, could this be why this is happening? I mean, there's certain meds that like I'm so familiar with because I know, okay, this can make them dizzy. This is going to drop their blood pressure, those kinds of things. But yeah, it's a huge factor. It's like a lot of the medications that we're taking to manage that tone we talked about, they can make people exhausted. And so it's like, okay, like, is the juice worth the squeeze? Is it worth taking those meds? Is there something else that could be done? But some of those medications, you don't want to just stop taking them without talking to your doctor. It's like, I had a client when I worked in Texas that ended up in the ER because they decided to stop taking baclofen and they were just like, had a withdrawal. So it's like, it's a really good question to ask of like, okay, what are the risk benefits alternatives? What will happen if I stop taking this med? How do I safely do that? Because again, we don't want to just make decisions on meds without talking to your doc.
Sure. And we do have Stroke Prevention Saturday coming up on April 5th, and our pharmacists will be there that will help with med reconciliations for folks too. So that's always a great, it's a great opportunity to sit down with a pharmacist while you're there. So what does when somebody has an appointment for physical therapy, what does a typical appointment look like over, if they wanted to come see you?
So typically we'll do an exam on the first day, try to capture like, what does this person want to work on? Like what impairments exist that we need to consider? Just trying to get an overview. That's the big thing because I can never measure everything I want to measure in the first day. There's just too much. So we kind of pick and choose, okay, what is the priority for this patient? Can I get an idea of, again, what's going on with their visual system, their inner ear? Like, can they feel their body in space? Basic things like that. But typically we'll do about 40 minutes and then our sessions are about 45 minutes or so.
Okay. And then about how long does somebody tend to see you?
So it really depends. It's such a tough thing because, again, like insurance is such an annoyance because I never want to look at that. I always try to just look at the patient and say, okay, what do they need? But it's like reality is like, okay, well, what is insurance going to cover too? And then how do we make that work for that individual? It's like, I know right after the stroke, we can really justify seeing somebody for a good chunk of time because it just happened. And then it's like, okay, can we get them to the highest level possible? And then can we maintain that? And then maybe they come back in 3 months later, 6 months later, and we do that again. But it's like it's one of those things where we're really like, okay, can we show the medical necessity? Like, do you need our skills to change things, or are things kind of staying where they're at right now? It's really a tough area. It's like,
Okay.
yeah.
Now, if somebody wants more information regarding TMC outpatient therapy, I've put the phone number up. It's 520-324-7005. I know you do require a referral for, if somebody is looking to come for physical therapy or occupational therapy as well, right? Or speech therapy, any of those. What could you explain a little bit about, would somebody be referred for both PT and occupational therapy? Do they usually do you normally do that like simultaneously or is it something that you work on one and then move on to the other?
I forgot to mention, actually, I'm glad you asked that, Maya, is we're one of the few places you actually can get all three disciplines in town because that's not everywhere. And we actually do like work as a team to treat you. What a concept. But yeah, ideally, if the person needs all three disciplines, like they can try and do that all at once. Sometimes that's too much and people will just start with one discipline and then gradually add more things. Some people just can't tolerate doing that much therapy. So but yeah, if they want to do all three and there's a need, like that's definitely an option.
And is there anything, the last question I have is there anything that you can do at home to make your house more accessible for a loved one that may be recovering from stroke?
So I think that really depends on what their needs are. But I mean, the classic thing we always think of is like, okay, is there 36 inches of clearance everywhere? Like, this is terrible. I'm constantly in my house. I'm constantly like clearing things out of the way. And it's like, it drives me crazy. Like people leave drawers open and things. And it's like, no, like keep it clear. Like, what if we need to run out in a fire? Like it sounds really stupid, but it's top of mind, of course, because I'm a PT. So I'm just like,
Sure.
Anyway, and small dog running around. So yeah, first of all, just like, is there clearance? And then the place I always think of is the bathroom too. Like, do you need a tub transfer bench or something to make it so that it's easier for the person to safely get in and out of the tub? Because that's a big place. It's like slippery. That's a whole area. In fact, people will do like a home evaluation, have home health come to you and say, okay, like actually assess this. I believe there are some resources in town too. I forget if it's the fire department, but I think Pima Council on Aging has some info on that about like someone coming out and actually looking at your home.
Yeah, well, I know there are some forms that you can also sort of go through, maybe rugs, loose rugs. That's always a big one, I know. And I love that you mentioned, the bathroom, right? Because that's places where people really might need some extra assistance depending on, how their stroke was when they get home so that they're safe in their house. So I want to thank you so much for being here today. I'm going to wrap up with our online audience and send it over to you for any questions in person. Thanks again, Geneva.
Thank you.
Thanks for being here. We look forward to seeing you again. We'll be back on next week. We'll be moving on into our healthcare decisions month. In addition to that, on Wednesday, April 2nd, we actually have two presentations. We've got You're Dead, Now What? Exploring Body Disposition Options. And that is on Wednesday, April 2nd at 10 a.m. with Pima Council on Aging. The second presentation that day is Circulation Matters, Identifying and Treating Peripheral Arterial Disease, or PAD. That is again on Wednesday, April 2nd at 2 p.m. with Dr. Cody Kramer. If you are interested in either of these talks, please give us a call at the office. We'd be happy to get you registered. The phone number is 520-324-1960. In addition to that, we also have Stroke Prevention Saturday coming up on Saturday, April 5th. You can again call our office at 520-324-1960 if you are interested in registering for Stroke Prevention Saturday. We do hold that over at the main hospital in the Marshall Conference Center. It's a great way to assess your risk of a stroke. As I mentioned during the presentation, there will be our pharmacist will be there. You will receive a variety of tests that are included, and then get to sit down with a provider afterwards to go over those risks of a stroke. So again, please give us a call at 520-324-1960 if you're interested. Thank you so much. We look forward to seeing you next week.